A very good morning, esteemed guests, participants, and speakers, my dear teachers. Welcome to the second day of this International Conference on Injury Prevention 2023 in Sri Lanka. We are gathered here to have a vital symposium of the day on elderly safety under the theme of empowering longevity, safeguarding seniors' safety, as well as preventing injuries. This symposium has been jointly organized in collaboration with the College of Community Physicians of Sri Lanka. In elderly, the injuries can occur unexpectedly, leaving individuals and families grasping with profound challenges that follows. Ladies and gentlemen, as we listen to these expertise and exchange our insight, as well as collaborate on multiple solutions, let us keep in mind that our collective effort can make an impact on elder safety. Now, I'm really pleased and very humbled to welcome onto this podium Dr. Shiromi Madogi, the president of the Extreme College of Community Physicians of Sri Lanka, as well as Professor Sunetra Pereira, professor of demography of University of Colombo, to come up to the stage and graciously chair this symposium. Their wealth of knowledge and expertise will undoubtedly enrich our discussions and also guide truth on this important event. Thank you very much for your attention, and let the symposium begin, Madam.
Good morning, and thank you very much, Dr. Sahan, for your kind introduction. And I think we too need not to introduce again, so cutting down the time. So we'll straight away start the symposium. Actually, this symposium is on empowering longevity, safeguarding seniors, safety, and preventing injuries. So I think I need not to tell all the details because we have three eminent speakers today to expose what is happening, what is available, what we need to do, and all very rich information. So with that, actually, we are very much happy to announce that this is a very timely need symposium as well as a timely need conference, the injury prevention, that we as Sri Lankans, we really need it because we see a lot of demand, unmet needs, and all those things. So it's a good way forward, eye-opening for policymakers, program planners, and all implementers as well. So I would like to say a big thank you to Directorate of NCD and especially DDG, Deputy Director General, Dr. Champika Wickramasinghe, and Director Non-Communicable Diseases, Dr. Samidhi Samarakon, and also the consultant community physicians, Dr. Samitha Siritunga and Dr. Sherin Balasingham, and all the other team members for raising this timely need issue. And also I'm happy to be the partners or the collaborative partners for this symposium, the College of Community Physicians of Sri Lanka, and I'm really proud to declare it as the president of the College of Community Physicians. So with that opening remarks, I would like to, actually it's my privilege to introduce my colleague and Professor Shamini Prathapan for the first speech or the delivering of the information to you. And Professor Shamini is the Chair Professor of Community Medicine at the Faculty of Medical Sciences, University of Sri Jawadanapura, And she is also a public health specialist, bioethics and journal editor. Of her 18 years of teaching career, she has been working as a professor since 2007, teaching many undergraduate and postgraduate for many MSc, MD, and PhDs to a successful conclusion. Professor Shamini has been occupying herself in journal editorial system nationally and internationally. She is the co-editor of the Journal of the College of Community Physicians of Sri Lanka for nearly a decade. She is also the editorial member of the Ceylon Medical Journal and the Sri Lankan Journal of Health Research and many other international journals. She also an international survivor to survey ethics committees, both nationally and internationally, and a reviewer to review the quality of undergraduate and postgraduate courses. Shamini has worked with many international organizations such as WHO, FPA, UNFPA, UN Habitat, UNESCO, and with GFDM and Ministry of Health Sri Lanka. Professor Shamini has more than 200 peer-reviewed articles and oral communications in her capacity. She has authored many books on public health and ethics. She has been conferred many research and teaching awards and grants both nationally and internationally. Her special interest, other than epidemiology and statistics, are mental health, NCD, and elderly care. So I'm honored to invite to you, Professor Shamini, to the podium. Over to you. So just before you start, Shamini, until they get ready. So each presenter will get 15 minutes. And after all three presentations, we'll have a Q&A session. Thank you.
Okay, a very good morning and sorry about the glitch in the technology. So we most of us here today who are quite, I guess most of your experts or have some special interest in geriatrics know that it takes a child 1 year to acquire independence movement and really 10 years to acquire independent mobility. Whereas an old person can lose both in a day. So this was really told by Professor Bernard Isaacs in his books, in his one of his most common book on challenging in geriatric medicine. Right. So so what? Because we most of us in the audience here would know that all of us would have a loved one who has had an injury when we were when we were children, or even now as adults, we have seen somebody with an injury in our life. So these injuries, they recur. They would have serious consequences sometimes. But if it is an adult or a senior adult even, it may really, it may not be a serious consequences. So we all know that falls or injury, they occur at all ages and are inevitable part of the bipedal gait and the physical activity. So again, so what? Because they're going to get better anyhow. So right, I hope it gets better now. Right. So again, so what? Because we all know that it is part of the inevitable part of the bipedal gait and physical activity. So why are we so worried about it? Because we know that the Global Burden of Disease study reports that about 17 million years of lives are lost from all falls, right, in 2017. Now, remember, falls, especially in an elderly, they are multifaceted. And we also know that there are so many domains. When a person falls, the problems are in so many domains, such as physical, financial, psychological, especially, and social. Both of these, which we don't look into a lot, such as loss of confidence, social withdrawal, loneliness. So those are aspects that we really have to look into. And definitely what we are here for today, governmental and community-related consequences of falls. And that's what I'm saying. Government and community related comes with a big cost to us, because in high income countries itself, it is known that 1% of healthcare costs are fall related expenditures. Remember, it's all falls really. So Skelton and Todd, who are economists and who are geriatrician specialists, said that even a minor fall in an older adult could end up in fractures due to weakness of bone, in turn resulting in permanent immobility, which could lead not only to a significant cost to the country as a whole, but also to the caregiver and to the family itself. So with this background of why we need to understand the elderly injuries, chairpersons and the audience, I'm here today to give you all to understand more about the elderly injuries and examining the epidemiology and the common types of injuries in relation to Sri Lanka. As I said, so what? Do injuries matter? They do matter, because I guess from the time that I was a consultant community physician, or even when I joined the university, this has been the leading cause of hospitalization in Sri Lanka. We have never gone down from that top rank. And we also know that through research and through the annual health bulletin, that falls can be ranked among the most common home accidents among people age 60 and above. And definitely it does matter, because what I told you all about with relation to the cost. So do injuries matter more in the senior adults? Definitely another yes. Because why? As you all can see, sorry about that. As you all can see with the population demographic pyramid, you could see that Sri Lanka is at the moment enjoying a demographic bonus. What is this bonus? This is that we are having a high 67 or about 70% of the working population is the bonus that we're having at the moment. Now, 12.4 of the total population in Sri Lanka at the moment is above 60 years and above. Unfortunately, by 2041, 1 in every 4 person is expected to be an elderly person in Sri Lanka. which makes Sri Lanka having the oldest population in South Asia. The last point seems to be a bit, seems to be something that we have to look out for in relation to Sri Lankan demographics. So with that, are we doing better in relation to injury surveillance in Sri Lanka? Yes, definitely. Because we do have an injury surveillance system. We did not have one until 2017, but thanks to the Ministry of Health and the NCD unit or the NCD Directorate, we do have one. We do have now one, but still until 2017, why I'm saying is that it's getting better, is until 2017, we did have data from the IMMR and from other places that were not complete. It was not up to date. It was really complicated a lot. And the worst part of it was the reliability was questionable because we got the data from police, Registrar General's office, or even unpublished or published research. So we were not doing any better in surveillance until 2017. So that comes to the crux of my lecture. Are we doing better after we started surveillance? So looking at the trends, you can see that 2018 is where we started our surveillance. So this is national data. 2019 was quite high. And then 2020, 2021, we had fallen a little bit in relation to the incidence. Now, 2021, I hear that the data collected is not completed yet. So if we leave out 2021, the trend seems to be sort of going down a little bit in terms of admissions to hospitals for elders. Now, when we look at the incidence rate in 2019, because that's where we had the highest peak for the last 4 years, we have an incidence rate of 1,622, right, per 100,000 population. Now, when you compare the incidence rate with the other countries in the world, you could see that the Northern and the Central Asia and the Eastern Europe also do have high rates, right? So you can see here that Sri Lanka is a little bit better because 1,600 falls within the light blue category. So definitely we are better off in terms of incidence rate. There's always a but. If we look at the age standardized cause-specific mortality rates for Sri Lanka, right? Now, why do we need to look at age standardized cause-specific? Because we do know that countries with the highest incidence do not necessarily have the lowest or the highest cause-specific mortality rates. Now, when you look at this graph, when compared to this graph, where we had high rates in the North and the Eastern Europe, when we look at the cause-specific mortality rates, the shift suddenly goes to the Southeast Asian countries like India. So how is Sri Lanka doing in terms of cause-specific mortality rates? So when we calculated for 2019 to 2021, the cause-specific mortality rates, age standardized cause-specific, you could see that in the higher age group of more than 80 years, it's as high as 42.37. And in the younger age groups, 60 to 65, it's around 17. So are we doing better in terms of mortality? I would say a definite no, because we are here at the orange region where the cause-specific standardized mortality rates are as high as the countries that, are at the highermost levels of the age-specific mortality. So once I looked into that, then I went back to what the mortality, just the crude rates are. And when you look at the patients who had died at the hospital, from 2019 to 2020, there had been an 83% increase. And from 2020 to 2021, there had been a 13% increase. Is it because of the surveillance that have been started? Or is there a real reason for an underlying increase of mortality? We need to dig in further. Now, looking at the age categories from 2019 to 2021, it is the same as in any other countries. As the age increases, definitely the mortality is increasing. So it is the same as in any other countries. Looking at the incidence of patients who have had an injury or any type of injury, Western province yes, it has always been high for any kind of diseases. Eastern and northern, yes, that is also on the rise. But I'm more worried about the three provinces which are under the poverty line, namely UVA, Southern, and North Central. So if we are to do an intervention, I guess these three provinces should be the province that we need to target at, because they are way below the national level, and with an increase in 2021, in which we have not still collected all data. With regards to gender, again, we could see something which is quite common with all other international countries. We have a high rate of males, and even the death is more among the males. Are these injuries mostly unintentional? Yes, at 60 years or above, they are mostly unintentional. Now, the rest of the lecture, or what I'm going to say, is going to be based on the causes for these unintentional and intentional injuries. And the causes, I'm going to connect them with the DALY and with the years lived with disability. Because at that stage, at 60 years or above, when they do have an injury, how is it going to affect with them being a disabled person or being a differently abled person? Now, if you look at the body region affected from 2017, the lower limbs have been affected. At lower limbs, upper limb, it's more than around 50%. So the limbs are affected definitely higher. But if you look at the YLDs in regards to the males and females, the males do have a higher years lived with disability, which is about 13.3%, whereas the females have it about, it's a little bit less, which is about 10. Injury nature. We do know that most of the elders who are admitted have a superficial injury, but when it comes to an open wound or even a fracture, 13.5% do have a fracture. So when you look at the years lived with disability versus fracture, you could see that in the males, it's quite high. It's nearly 1,117.4 rate per 100,000 population. When you look at both sexes, it's about 991. So anybody with a fracture and years lived with disability is quite high, which is quite a concern for a country like Sri Lanka being in an economic crisis as well. Burns. Is there a higher proportion of elders with burns? Definitely. You could see that 2021, we have a higher rate. But when I looked at the years lived with disability, surprisingly, I found that the females had a higher years lived with about 117, whereas the males, this was the only graph where the males dropped down. So when I looked into the burns in relation to females and males, we could see that the females definitely were having a high rate of burns, maybe because of our cultural practices in Sri Lanka, where the female is supposed to do the household cooking, right? But this also has to be digged in further. The total years lived with disability, I would say that Sri Lanka is not far off from all other international countries, because we have a high years lived with disability with the males at 2,931 and a mean for both at about 1,860. So we are near there with India and with most of the Northern American and the North and the Mid Asian countries. Suggested areas for improvement. A big kudos to the two health-related directorates in the ministry, the Directorate for Youth, Elderly and Persons with Disability, and the Injury Prevention and Control Unit of the NCD Directorate. A really admirable job, because it's not easy with the services and the economic crisis that we are having at the moment. So just a few suggested improvements, areas for improvements. Definitely, we have to define falls, whether it's research or at the ministry, because I think it would be better to go with the WHO definition so that we can compare. The other thing that I see is that the elders are not being screened for the risk of falls, right? So we do need a holistic care for falls risk assessment, because we all know that people with diabetic hypertension is also on the rise. We do have clinics. So it is just a holistic care approach that we need to assess whether they are at a risk of whether they are having, they will be having a risk, they could have a risk of fall in the future. The PMCUs, again, I suggest that we start screening for the risk of falls at all PMCUs so that we can bring down the incidence of falls or any injury related in terms of elders. Thank you very much.
Thank you very much, Professor Prathapan, for your very informative presentation. And I think I'll hand over the mic to my co-chair.
Yes, thank you. So we'll go by the second presenter. Let me invite our second presenter, Dr. Silva. Dr. Silva is a senior lecturer in medicine, Faculty of Medical Sciences, University of Sri Jayawardenepura. He is an honorary consultant physician, Colombo South Teaching Hospital in Sri Lanka. He was past secretary and treasurer of Sri Lanka Association of Geriatric Medicine. He trained in many areas in the UK. No, there is then at the Brook Hospital, University of Cambridge, United Kingdom. He has numerous publications and has delivered invited speeches nationally and internationally. We would like to cordially invite to deliver your presentation. Thank you.
Thank you. Thank you for inviting me to deliver a talk on falls in older persons, as well as to do a little bit of musings on the medical aspects of falls. The task is quite difficult with a limited number of minutes, but then again, I try to do justice. So falls, we take it for granted. Sometimes we look with, sometimes we think that, okay, it's just a fall and no point talking about it. We fall and then we succeed. As you see on your right side, there are people who succeed. And on your left, you see people who have not succeeded. The topmost image, for those who don't know, that's a father of the nation who died after falling from a horse. And also at the bottom, you see the Indian president who had a collapse and who succumbed sometime back. So can all the king's horses and all the king's men put all the elders who fall back together? That's our question. So the WHO defines falls as an event that results in person coming to rest inadvertently on the ground or floor on the lower level. Very simple definition. Might think, why do we have to have a definition like this? That what does it make any? Does it make any difference to our life? But it's an important problem which is often neglected, and it affects the quality of life as well as health economics, as Professor Prathapan mentioned. And you see that as one advances in life, that the number of falls increases. More than 65 years of age, 30% will fall. 30% of our older adults will fall. That's 1 out of 3 roughly. And as one approaches the age of 80, 1 out of 2 would have a fall. So it can be a single or recurrent event, but recurrent falls, what it means is somebody having more than 2 falls, at least in a span of 6 months duration. So falls are all multifactorial. We'll talk about that in a little while. It involves physical, psychological, as well as situational. My colleague, Dr. Malsha, will also address some of that. And there is also always a vicious cycle. Falls will lead to a fear of falling. The fear of falling leads to reduced activity, reduce muscle strength and balance, and increase risk of falling, again giving rise to falls. So you see that it goes and round and round. So all what you need to do is you have to break this cycle at one particular point by conscious decision making and intervention. That's what we are going to talk of. So the consequences are many. There are physical consequences leading from fractures, head injuries, burns, carpet burns, or abrasional burns, dehydration, There's also a condition called long life, which we'll talk of, and it also leads to a worsening medical problems. When somebody falls, there is dehydration, there is injury to the muscles, there is various metabolic disturbances that happens. It leads to increased risk of institutionalization, increased mortality, and reduced life expectancy. With the mind also, there is a lot of things that happens that leads to increased dependency, stress, fear, loss of control, loss of self-esteem, being embarrassed. When somebody has a fall, that may trigger and tell that there is a tendency for frailty, and you see that dubalatavya is what we see in Sinhala. There is some stigmatization that may come across. So long life, when somebody has a fall and who be on the floor for a prolonged period of time and they are unable to get up, usually for more than 1 hour or more. Don't see it very much in our country because we have at least somebody with our older persons. But if somebody is living alone, especially nowadays, with the current trend of migration, older people living alone without any help, we might see this more and more. The implications are many. You see that there is delay in getting medical treatment. They'll be having a condition called rhabdomyolysis, where there's breakdown of muscles. I mentioned about burns, carpet burns, dehydration, ulcers, etc. So you see that it's something that we have to open our eyes, especially with regards to planning healthcare. You also have this condition called post-fall syndrome. We take again this for granted. After a fall, you see there's deconditioning of our older adults. There is increased dependence, loss of autonomy, lead to depression, confusion, and restriction of daily activities. So it's a entity where there is both medical as well as psychiatric involvement, giving rise to many problems. So we have a center of gravity and we are suspended upon our base, which our feet. And when the center of gravity is dependent and this the maintenance of posture is dependent on sensory inputs from as well as the muscles and joints. And we should be able to have quick reflexes. And you see that as one advances in age, these are affected. You see that there are various risk factors. Start off with the intrinsic risk factors, which are many. Physical risk factors, age itself, as one ages, the risk of falls increase. Previous history of falls, one fall will beget another fall. Reduce mobility, reduce stability, increase a low BMI, and sarcopenia and frailty. We also have to think about functional status and impairments of faculty, especially the activities of daily living and instrumental activities of daily living, which I'll be talking about. And all these numerous medical problems, I won't rant them out. You see, and you will understand that those are contributing. Psychiatric illnesses, especially dementia, cognitive disturbances, depression, delirium, and I have put in italics our entity, fear of falling itself. Medication, antihypertensives and diuretics, antipsychotics, antidepressants, cognitive enhancers, all of those will increase the risk of fall. Particularly polypharmacy, when there is more than 4 or more drugs that are in the list of medication, that has been shown to increase falls. From intrinsic factors, that are the patient factors, we move on to extrinsic factors. These are things that we have to talk of. Safety at home, safety at workplace, safety at hospitals, all of these. So whether there are ground surfaces which have loose carpets, loose rugs, our floors, are they slippery? They have slippery tiles, where there's moisture, water, maybe even excrement on the floor. You see how if we could change our environment into some clear and organized nature, how it might lead into clear walking paths and clear areas for people to move in and reduce. Don't forget our furry friends, pets, furnitures, and nowadays, most important things, all these wires that are going about. We have cell phones, we have laptops, we have various electrical appliances. All of those needs insulation and good stabilization be aware of that. Lighting has to be addressed about good lighting for wards, especially with regards to prevention in the health sector. Slippery floors have to be dealt with. Uneven floors, we see that it happens. We do some construction and then we forget to clean it up, polish it up and nicely conceal the injury that has been done to the environment. Bathrooms, inappropriate walking aids. Walking aids are very useful for people to mobilize, definitely, yes. But remember, if they are not used properly, that itself can lead into falls. Worn out soles of the shoes. And even in a walker, this thing called a ferrule, this black rubber bung that is there. How many of us are concerned of replacing a rubber bung, the sole of that walking aid? That would also improve. Bring into notice this thing called Diogenes syndrome, which is more and more detected, appreciated in among older adults. It's again a physical as well as psychological problem where there is hoarding of things. We see that our older people, they hoard a lot of things for, sentimental reasons. Maybe papers, maybe books, maybe various bottles, plastic items, etc. So all of those compulsive hoarding can lead into unsafe environment like that, right? So how do we deal with this? This is where we need a public partnership, public-private partnership, as well as curative and preventative healthcare. People over the age of 65, please, we need to get a system to make sure that we detect whether they have falls or recurrent falls in the past. Abnormalities of gait and balance need to be done, especially those who have falls in the past. But also we need to actively look at people above 65 years of age with regards to finding out whether they have falls in the past and whether there is a tendency. So these are some screening things that we have to incorporate into our system. Simple things. Think we, as geriatricians and people who are interested in elderly care, we advocate this simple test, which is called timed up and go test, which can identify frail and people who are at risk of falls. All what you need to do is to get a person to get up, walk a distance of 3 meters, come back and sit down. And you see where, at least if somebody takes more than 10 seconds to do that, there is a risk of falls. There are other things that can be done, simple things where you get a person to step up and step down, up and down, up and down, up to 8 steps. And you see if it is more than 10 seconds, again, if somebody is taking, that is again at risk of falls. Another one called sitting and rising test. All of these can be done at the point of the person being in the ward. The nurse can do, the house officer can do. We need to get this going into the system. And we need to do some assessment. These are basic medical or nursing assessment that can be done. Every person who comes, older adult, more than 60 years of age, at least we can have a checklist to see whether there are things. Especially when somebody comes with a fall, you need to ask whether they have prodromal symptoms, dizziness, lightheadedness, whether they can remember things happening, whether they remember the hitting on the floor, whether they were falling. So that's called SPLAT with the mnemonic. The P stands for previous falls history, which I spoke of before. Also, you need to be concerned whether the patient is saying, I must have had a fall. Like that, if somebody is giving answer. Location, whether it happened inside the residence or the known place or outside. If somebody has a fall in a known place of location, that means the risk of fall is greater. Activity at the time, what were they doing? Especially with adults, whether they were shaving, whether they were wearing a tight collar, whether they were in a confined space, all of those will lead into pathological syncope. The time of the day and whatever trauma that they have got. Important tests, very difficult to do. All what we have to do is to do this brown paper bag test, look at the patient's malla to see whether there are medicines that are duplicated. You see that there are people coming these days with, fish oil and magnesium, calcium, glucosamine, all because they are sent with love from people, the children who have migrated, maybe. So we may be duplicating this. So please, and also they may be taking 1 or 2 of the same drug, maybe the same diclofenac sodium. So history, other things like incontinence, environmental hazards, osteoporosis, social circumstance, all of these have to be looked into. Look at, for osteoporosis, there is a thing called the FRAX model, which is validated for Sri Lanka by the Ruhuna team, which can tell about the risk of fractures with osteoporosis. Simple things like looking at activities of daily living and instrumental activities of daily living. Look at cognition. There are various tools. I think Dr. Malsha will address this, mini mental score, mini cog, etc. Look for depression. And importantly, things like this, the false risk assessment tool that can be done. This is a simple thing, again, which can be used in the ward at the point of admission. The nurse can tick, the house officer can tick, which will alert. I think this is a summary. This is the crux. This is the pinnacle of what this talk is. If we can have a protocol like this and get it into existence, that's going to be important. The bread and butter of geriatrics, a common comprehensive geriatric assessment is needed, where all have to stick together. The physicians, the psychiatrists, the therapists all sit together and see how we can improve the patient's outlook. Multifactorial interventions are needed in strengthening and balance training, changing medications, improving the cardiac functions, etc. Where the therapists come into being, the occupational therapy especially, our hospitals, whether they have handrails, grab rails, toilet seats which are elevated and accessible, and that's very important. And then importantly, the 3 levels of prevention. Primary prevention is to prevent the risk factors, make people aware of this, not to just shudder off that fall is a fall. Exercise programs, Tai Chi, yoga, autogas, exercise training that can be done. Secondary prevention, where medical teams have to partner and, optimize the medical diseases and eliminate risk factors. Not so widely available in our setup and maybe not culturally appropriate, but unfortunately, these may have to be done for people who are frequent fallers. Minimizing the impact of falls with hip protectors and headgear. Headgear might not be practical. So let's partner and try to help our older adults and try to fix and like all the king's horses and all the kings. Thank you.
Thank you very much, Dr. Shahan. And our next speaker is Dr. Malsha Gunathilaka. And I'm honored to introduce Dr. Malsha Gunathilaka. Dr. Malsha is an old age psychiatrist, Colombo South Teaching Hospital. And she received MBBS from Colombo and qualified as an old age psychiatrist in 2018. And she is a member of Royal College of Psychiatrists, United Kingdom. And she has many publications. And Dr. Malsha is currently involved in quality improvement projects. And she has also been involved in surveys on nutritional status and iodine deficiency status. And she has contributed to the establishment of an official blog at MRI. So with that introductory note, I would like to invite Dr. Malsha to have the presentation. Thank you.
Thank you, Dr. Shiromi. Good morning to all of you. So I think since morning, we were talking about injuries and their prevalence, and then we talk about falls in elderly people. Now, in my talk, I'll be discussing about the cognitive health. what is cognitive health, and what are the disorders related to these cognitive functions, and how these cognitive disorders are related to injuries. And at the end, I'll be talking about what we can do to prevent injuries in people with cognitive disorders. Okay, so I thought that first we should talk about cognitive functions for us to have understanding about what is this cognitive health. So these are the fundamental, the main cognitive domains that we are always talking about. So memory, we all know that this is the domain, the cognitive function that we use to remember and recall things. There are different subtypes under memory. So we talk about episodic memory, which related to events in our life or in general. And then we have these semantic memory, which is important to remember the facts meaning of things and general knowledge. And then we have these procedural memory, which is related to the learned skill. For an example, the skills of riding a bicycle or using some instrument. This all comes under in procedural memory. So that's memory domain. And then we talk about attention and concentration. So which is important for us to keep our focus on a task. Again, there are different subtypes under this domain. One thing is sustained attention, where we keep our attention on a single task for a considerable time. And then we have divided attention. So when we do two or more tasks at the same time, we need to focus on both. So we need divided attention. For an example, think of a situation where you are driving and same time you are answering to a telephone call. So you do two tasks at the same time. So your divided attention help at that point. Then we have shifting attention. So when you do one task, then quickly do another one. So you need to shift your focus from one task to the other. So you need shifting attention to carry out those tasks. And then we talk about the visual construction abilities. In this domain, it helps us to recognize objects, people, and places. So we use these skills to recognize people. When we see somebody that we know, maybe somebody related to us, friends, neighbors, relatives, or maybe a famous person that we know. When we see the face of that particular person, quickly our brain started working and then we recognize who that person is. And at the same time, we can recognize places and we can navigate ourselves in the space. When we go out of the house, we can find our way to the particular place and we can find our way back home. And we can find places inside our house or inside some other places so we can navigate ourselves. So visual spatial functions help us at that point. And then we talk about language. So that there are different functions under language domain. So speaking, reading, writing, everything comes under language domain. Then the fifth one, the executive functions. That is the mainly controlled by the prefrontal cortex. It's very important set of functions which is important for us to manage our day-to-day activities. So analyzing things, taking decisions, planning, so everything comes under these executive functioning. So when we look at these cognitive domains, we can understand how important they are for us to function effectively and safely in our day-to-day life. So when these functions are not going on properly, so we are at risk. Yes, then we talk about what happens when these functions are not working properly. So we label them as neurocognitive disorders. There are different types of neurocognitive disorders that I'm not going to talk all of it. But there are mild cognitive disorders and there are major cognitive disorders. The dementia is one of the major neurocognitive disorder where the person is having impairment in more than one cognitive domains. Okay, maybe memory, visual spatial, or maybe memory, language, or most of them with functional deterioration. In that case, we label it as dementia. We know that dementia is increasing in prevalence across the world. And at the moment, nearly 50 million of people live with dementia around the world. And it is predicted that this number will increase to 130 millions by 2050. So it's quite challenging. So what happened in dementia? So we talk about that dementia is a condition where we have this impairment in cognitive functions and daily impairment in activities of daily living. And other than that, these people also have behavioral and psychological symptoms or BPSDs of dementia. So these behavioral and psychological symptoms include aggression, having psychotic symptoms, delusions, hallucination, agitation, poor sleep, wandering. All these things can contribute or predispose the person with dementia for injuries. And they also may have neurological symptoms. Some types of dementias, they show neurological symptoms at the beginning. For an example, dementia in Parkinson's disease or Lewy body dementias, they can have these Parkinsonism features, recurrent falls, unsteady gait. And also the people with normal pressure hydrocephalus, they also have this unsteady gait and they have tendency to fall. And also any type of dementia, when the disease progresses, then they can have these neurological symptoms. So as a result of all these symptoms domains in a person with dementia, they predispose the person for multiple injuries. So there are studies which have compared the risk of injuries in people with dementia with normal population, and they have found the risk of injuries is high and the risk of injury-related hospitalization is higher among people with dementia than in compared to normal population. And then when we look at the types of injuries, the suffocation or choking is one of the commonest type of injuries in people with dementia. And then the accidental falls, then they have found that it is 2 to 8 times higher in people with dementia in compared to normal people of same age. And then accidental drug poisoning is again common type of injury because these people with dementia, they forget things easily and they can't remember whether they have taken medication or not, and they go and take another dose. So this is a frequent type of injuries we come across with people with dementia. And then road traffic accident. Again, people with dementia, they have impairment in these, when they have impairment in cognitive domains, especially these visual spatial, then the executive functions, they may not be able to navigate themselves in the road. They can't find the road. They get confused with the routes and they can't follow the road signs. And they may not be able to take right decisions because driving is a quite complex task. And if we miss something, so we can end up in accident. So it's very important for us to have a sound functioning of all our cognitive domains to drive. Because of that, the people with dementia, if they are driving, not only them, but also the people on the road are at risk. Then we talk about the other type of injuries, is homicide and suicide things. The studies have found that people with dementia are at risk of being abused or rarely being killed. So studies have found that the people with dementia suffer 5 to 55% of times from abuse or suicide, whereas it is around 3 to 27% in general healthy population. So financial abuse, physical abuse, and emotional abuse are common among people with dementias. And then we talk about suicide and deliberate self-harms. We know the deliberate self-harm is actually less in elderly population when we compare the rates with younger people. And suicide, on the other way around, the risk of suicide in general is higher in elderly people. When we look at these rates in people with cognitive impairment, especially in people with dementias, we can see that at early stage, especially we'll see that a high functioning person, when he or she gets dementia, at very early stage, the person may have insight and understanding about this disease and what is going to happen in future. In that case, the person may become depressed about the condition and may ended up in committing suicide or doing any act to harm him or herself. But what happened when the disease progresses? When it comes to the moderate severe stage, their cognitive functions are impaired and they may not be able to think, plan, and carry out any act to harm him or herself. That's why the deliberate self-harm and suicide risk is low in people with moderate to severe dementias. Other than these type of injuries, we talk about the fire accidents, burns, and also electrocutions. Think about a person with dementia who is still continues to cook using a gas cooker or electric cooker. So it's very common for them to forget to switch off the cooker. So it can end up in fire. So those are very common accidents that we have to pay attention if they still continue to cooking and using these electric appliances. So when you look at what are the specific risk factors which predispose these people for these type of injuries, we can see that moderate severe stage of the disease and living alone, having behavioral and psychological symptoms, being a female, and age between 65 to 74, and also having injury, history of injury within past 1 year are the predictive factors for further injuries in a person with dementia. So it's important for us to see as clinicians what we can do to prevent these injuries in our patients with cognitive impairment. The very first thing is to educate patient and carer. So we should inform them about the risk situation and also recognize the warning signs. So what are the things that we can cause injuries in these people, in what situations, and also what would be the safety things, safety intervention that they can do at home to prevent these injuries. The risk situations, for an example, the wandering. If the person is wander out of the house, especially at night, they are at risk of falls, road traffic accidents, getting lost, and also situation that we talk like driving, and if they have access to dangerous tools, weapons, and if they still engage in cooking, bathing alone, or if they live alone. So those are the risky situations that we have to identify and inform the family and patients. And then in general, improving the cognitive functions can help to prevent injuries. So we know that there are several strategies that we can use to help with cognitive function. One thing is cognitive stimulation, doing tasks to keep the brain active. There may be kind of a number game, the word game, or there are different tasks and there are different manuals to do these cognitive stimulation therapy for people with dementias. Another thing is cognitive rehabilitation, where we do different activities to regain some of the lost functions. And then if the cognitive adaptation, in cases where we can't approach with cognitive stimulation or rehabilitation, we can use alternative interventions to mitigate the effect of that cognitive impairment. For an example, we can ask person to use reminders to remind them to take medications. So that is cognitive adaptation. So there are different strategies. We can get the help from the occupational therapist to plan these interventions. Then I'm not going to talk about the falls because Dr. Shehan nicely explained these aspects. So we will move to the next part. The choking. I told that choking is another common type of injuries with people with dementias. So there are several types of people with dementia who are predisposed to risk of choking. The people who are having stroke, people who had already had brain injuries, spinal cord injuries, who are with Parkinson's disease, multiple sclerosis, ALS, cerebral palsy, and people with advanced dementia, because they already have difficulties in swallowing. When we identify people with risk, we can get help from other professionals to get the swallowing assessment done. So for that, we can get the help of ENT surgeon and we can get the help of speech and language therapist, and they will give us the assessment and also the intervention. The other practical instructions that we can give for the families and patients are on the way that they should sit or hold head when they eat, important. And also there are other strategies to help it swallowing to make it easy and safely. For an example, eating soft food and drinking quite thicker drinks that would facilitate drinking. And then medication, prevention of medication overdose. There are simple strategies the families and patients with dementia can use. One thing is using a pill box. They can use a pill box to organize their medication rather than keeping them in separate bottles or covers. And then they can have a routine to help with taking medication. With the they can use meal times to take medications. And also if they have a lot of, we know that there may be multiple medications in different boxes when you open the drug cupboard of an elderly person. So, so many unnecessary medication may be there. So we can throw out those unnecessary medication and keep the relevant medication only in those drug cupboards. And also, if the person is always forgetting and the person is the one who is taking medication, so we can keep the medication locked in a safe place to avoid that person having access to those medication. And we talk about the driving. So it's important for us to identify the risk at the beginning of the assessment. So if the person is still driving, and if we have any concern about the patient's ability to drive in and meet with the accident, it's our duty to first inform the family and patient to inform the driving license authority and do the assessment and see whether this person is suitable to continue driving. If the family is not going to do that, it's as a treating clinician, it's our role, it's our duty to inform the driving license authority. And then at the same time, if there's any risk, we should advise person to stop the driving if person is not going to do that. So family can keep the keys and vehicles away from the person. And the fire accidents. So it's important if the person is forgetting and forgetting to switch off the cooker and if there has been multiple accidents, so they should stop cooking. So if they are going to do it, it should be done under supervision. And having fire alarms is another option, but it is not very common in Sri Lanka. So those are the simple strategies we can use to prevent accidents in people with dementia. I think as clinicians, so these are the things that we need to do during our initial assessment, and also do intervention during planning the care for people with dementia. Thank you.
Okay, thank you, Dr. Malsha. And floor is open for question and answers.
No, that's not in practice. Actually, I am doing a study. Thank you for raising that up. At the moment, started on assessing falls in hospitals. We are using the FRET protocol that is there. There's another one called Berg's test, which is a bit cumbersome. But this, I think, is a very, very, it's a 10-point thing that can be done. I think it's been practiced in certain private hospitals, I know, but it's not done widely used in a government setup at the moment, although there are various other things like the tug test, that timed up and go test, and the frailty assessment that's been done. But I think it's high time that we have some protocol like that as a way of, identifying people who are getting admitted, because most of our government hospitals are not safe environments at all. So yes, that's where we are.
Thank you, sir.
So, are there any questions? Yes.
They know what are the problems they will encounter, and that would be a good opportunity for us because they are in contact with the health system quite frequent, and they are more educated people as well. So as a starting point, just to comment that whether we can do that, or at least is there any program going on nowadays? That is what I want to know. Thank you.
Yeah. Thank you. Any?
So yes, I more and more, I think our population is becoming older. Projections have been 2030. They say that 1 out of 4 will be older. But I think that is accelerated with the out migration as well as all the other factors that are there. Yeah, at the moment, there are few elderly care clinics that are being established. Kalubovila, we have an extensive one, and now by next year, 2024, there will be new consultants coming as geriatricians. So those are more aimed at outpatient levels, but then again, I think it is important that not only geriatrician or physician, but all individuals, including the public health medical officers, are geared. I think, yes, that we have to fish out from that. That's where curative and preventative sectors have to meet.
Okay, thank you very much.
Shiromi, I have a comment now. Actually, as speaker mentioned, now we have to go for a prevention rather than going for the clinical setting. Actually, now active aging make the difference, though it's a WHO slogan long ago, but we are not practicing it. I think we have to start it as now we are on the way of life cycle approach. I think we have to address it. Otherwise, now the outgoing migration, they are, as previous speaker also mentioned, to carer or caretaker. There won't be any carers or caretakers, will be ultimately the elderly only. So therefore, I think we have to be very concerned about that.
Okay, thank you very much for your concerns and suggestions and all the answers.
Yes, so just as a demographer, I think I should speak a little bit just to share. So as you have, first of all, I must congratulate all three presenters. So you have actually shared very informative and also very timely presentations by awareing so everyone about the risk of all the ages. I think Dr. Prathapan, Professor Prathapan, you have actually brought in the how the injuries and the other is and then followed by Dr. Silva. Shahan, Dr. Shahan, you have very important aspect the how the fall risks and also I think another important aspect Dr. Masha brought in the cognitive domain. So from the demographic point of view, as you correctly pointed out, one in every in another 30 years, then another 8 or 7 years time, we will be facing a huge issue. The burden will be more, I think, trigger in coming years. By 2050, it is projected 1 in every 4. Again, 1 in every 4. Now, 1 in every 5, more or less. So elderly, but when it comes to elderly at the ground level, because so you all shared at the hospital perspectives. So when we actually go to the field level, ground level research, we know that the health system is functioning in different, with different challenges. Because 2 weeks ago, actually, my personal experience with when I went to with my students to the field. So most of in Anuradhapura district, very remote area, all the persons actually we met. So they are very rarely accessing health, seeking facilities existing due to poverty. So because they don't have money to use transportation to go to hospitals. So when it comes to this, I think injuries or falls, so we have to have different strategies. I mean, outreach strategies. I think health system sometimes within the system, maybe within hospitals, sometimes we may not able to address everything. So best thing is if we can empower the communities, maybe through life cycle approach. So I mean, basically through schools and maybe generations. So we have lots of programs, but I wonder whether the health system can address kind of primary health care system. We have very good system, similar kind of thing if we can adapt in the future for older age care. So visiting at village level houses, I think that is going to be a very good model for us. I think everyone, we should actually support for those kind of initiative. I think implementation is going to be a very big problem. I think time is too short. I think I must thank you everyone for your participation and also for your insights to make this session success. Thank you.
Okay, thank you very much. And I just take 2 seconds and add some suggestion, because already with the government side as well as in collaboration with public-private partnerships at the ground level, implementation of activities already initiated. So now the thing is, we want to take these platforms as to turn these things into practice. So I think that's a good opportunity for everyone, because active aging is already started through the awareness and all those things. And also we have initiated this integrated care for older persons, where we started the primary health care level screening and all those things. But we need to strengthen it, make little bit forward in a speedy manner. So that's what we want. So I think it's a good platform. Like these forums are good platforms, because each of us has certain responsibility to fulfill. So understanding that, I think I would like to say a big thank you to all three presenters, behalf of Directorate of NCD as well as a collaborative partner for this symposium, the College of Community Physicians. And again, thank you very much.
Thank you, madam. Thank you, madam. So once again, a heartfelt thank goes to Shamini madam, Shahan sir, as well as Marsha madam for giving your insights today on this very valuable symposium. So let me now extend our special invitation to Dr. Shiromi Madhuige, as well as Professor Sunetra Pereira to come up to the podium, and we'll have a distribution of tokens of appreciation as well as certificates to these esteemed speakers. First, I would like to invite to Professor Shamini Pratapan, Professor of Community Medicine in University of Sri Jayawardhanapura, to come forward and get the tokens of appreciation as well as the certificates. Followed by Dr. Shehan Silva, a senior lecturer in medicine as well as consultant physician of University of Sri Jayawardhanapura. Shehan sir. Last but not least, Dr. Malsha Gunathilaka, a consultant in old age psychiatry at the Colombo South Teaching Hospital. Additionally, now I would like to invite Dr. Suraj Pereira, a consultant community physician of the National Cancer Control Program, to present the tokens of appreciations to our esteemed chairpersons, Dr. Shiromi Madhuige and Professor Sunetra Pereira. Your recognition and the commitment on this symposium and leading this symposium have lifted all the profits. So thank you very much. We do appreciate and we do express our gratitude. Dear chairpersons and speakers, before we move forward, let us capture this moment of this symposium with a group photo. Suraj sir, if you don't mind just staying with us for 1 second, with all the speakers, chairpersons, as well as Suraj sir. Marsha madam, yes. While this group photo has been taken, I would like to remember all the participants that the tea is ready just outside of this hall. You can enjoy the tea.
Good morning, everyone. Welcome back to the next proceedings of the day, Free Paper Session 5. Ladies and gentlemen, it is my honor to introduce the esteemed chairpersons for this session. Please join me in welcoming Dr. Sumal Nandasena, Consultant Community Physician, RDHS Kalutara, and Professor Sampatha Gunawardana, Department of Community Medicine, University of Sri Jayawardenepura, to take their seats at the head table. Over to you, sir and madam.
Is this working? Yeah, okay. Right. Okay, good morning. Without further ado, we will start the session. So others will join with us during the course of the presentations. Now, in this session, we have five oral presentations. So every presentation will get 8 minutes to present and 2 minutes to session of question and answers. So over to you, madam, to introduce the first presenter.
Okay. Thank you, Sumal. So the first presentation, the title of the presentation is Thematic Review to Assess Preventive Measures on Serious Incidents Following Falls at Hull University Teaching Hospital NHS Trust. The authors are Fernando G.H.S. and Makani Perva. So the presenting author will be Fernando G.H.S.
Good morning to all of you. Thank you selecting my abstract in this session. I am Dr. Fernando, Medical Superintendent at Base Hospital Udugame. This is a review. This is a review to assess the preventive measures on serious incidents following falls at Hull University Teaching Hospital NHS Trust. This is a 1,000-bed hospital with 10,000 staff, and it is the hospital where I did my foreign training. Falls in hospital account to 5th of patient safety reported in the National Reporting Learning System in the United Kingdom. A multifaceted intervention in hospital could reduce the number of falls. These are research findings. This thematic review set out to collectively review the learning and action required from a series of serious incidents reported by the service. This is my topic to identify the main reason for falls in order to take necessary actions to reduce serious incident of fall at Hull University Teaching Hospital. We know in the UK system, the incident reporting system are very strong. Each and every incidents are reported to the system, all are evaluated. There is a monthly patient safety summit conducted every week to assess all the incidents. By assessing, they select serious incidents and non-serious incidents. Non-serious incidents are closed in the unit level. Serious incidents are forwarded to the serious incident review meeting, which is conducted weekly. The relevant board should submit rapid review report on the serious incident. The serious incident meeting, the chief executives and chief medical officers all are participating to this meeting, and they identify whether it's actually serious or not. If it is serious, the team is allocated to do in-depth analysis. If there are similar type of incident report, they take as a collective incidents and appoint expert team. They analyze whole together to identify the reason. That is thematic review. The 8 rapid review reports of serious incident of faults took place between this period of time. The modified fault assessment tool, each and every patient when admission, this MFAT has to be completed by admitting nursing officer, and this was taken as a standard to review this with the team. The fishbone analysis, that is a tool which finds the causes, performed to identify the root cause for the incidents with review team. These are the incident reported during period as a serious incidents. These are term of reference in serious incidents. They bring together all the issues identified in each occurrence, treatment delay, identification of core theme in each, and recognize any trend that have occurred, measure against standard of care received by the patient, identify any system resource issue that may be contributed to the occurrence of breaches, individual clinical review for each affected patient, and individual aspect of each cause to be considered, determine the good practice, care, and services to the problem, root cause, and contributor factor, and individual basis to compile a consolidated report with an overview, root cause analysis, and action plan that address the ongoing problem. This is a term of reference for a thematic review. After evaluating all the incident by team, even we get information from the patient and bystander also. After we identify all patients are more than 65 years old. Of them, more than 50 are above 90 years old. All result fracture, 7 neck of the femur fracture and 1 hip fracture. Almost all patients identify as they earlier identify as risk of fallen by assessment, and preventive measures also has been taken. All the patients, but all have fallen and serious incidents happen. Why that? This is a fishbone analysis we conducted with team to identify the real cause with the all information. These are the main reason we identify the lack of close observation is the main reason. Poor mentality of patients. Most patients are dementic. Moving without assistance, they have moved away without assistance, heavy workload at work, inadequate staff, underestimation of risk by staff, only one incomplete fall assessment. You can see the what are the main reason. You can see top one, lack of close observation is the main reason. Then mentality of patient, move without help, and heavy workload. These are the main reason of fall. The collective decision were given as this for the all 8 serious incidents were due to this reason. Even they have taken measures to prevent. The conclusion, all patients identified as risk of fallen. Preventive actions were taken according to the guideline. However, mental status of the patient and lack of supervision lead to serious incident with fall. The team recommended to offer one-to-one care or close observation for high-risk patient on fall to prevent further incident, because all they have given preventive action were taken, fallen, the serious incident happened, patient this is a very high cost for the UK, the hospital for repair of this fracture. Therefore, we recommend us to take one-to-one care, close supervision. Thank you.
Thank you, Dr. Fernando, for keeping to time. So now it is open for discussion. Any questions, please?
Mic, please.
Mic.
Limitations of this study.
the if we can because of similar incident, we study the team whole. If you can study individually, but it will take long time. If have different long time period, we can go in further depth to find further reasons. Other than, I think this is a good review, which is not done in our country mostly. We can, I think this good. There are no lot of eliminations.
So your sample size is 8, I said.
No, it is the serious incidents confirmed by the serious incident committee that during that period.
Yeah. So what is the total number of cases that you have studied?
Only 8.
8, yeah.
From the serious incident committee decided the 8 serious incidents fall happened during this period. All the incident we studied.
Okay.
Yes.
So the period is only 4 months, like.
Yes. Yes.
Yeah. And during that period, only 8 serious incidences
Yes.
happened. So
because
how?
I was attached to that quality governance unit for 4 months, because
Okay.
I did my appointment 4 months and 2 months. Therefore, I was there that period. I was appointed to this group during this period.
Okay. Okay. Thank you, Dr. Fernando. Right. We'll move on to the next presentation. So shall we show the usual appreciation to Dr. Fernando?
Okay. Let's move to the next presentation. That is on prevalence and associated factors of needle stick and sharp injuries among healthcare professionals in a tertiary care center in southern Sri Lanka. So Dr. Vikram Singh is presenting the paper.
Yeah, please.
Thank you, Sir Chairperson. Good morning to you all. This study is on prevalence and associated factors of needle stick and sharp injuries among healthcare professionals in a tertiary care center in southern Sri Lanka. Needle stick and sharp injuries are serious occupational hazards for the transmission of bloodborne pathogens such as hepatitis B, hepatitis C, and HIV viruses. Unsafe injection practices, including recapping and disposing needles, are major risk factors in the occurrence of NSSIs in both healthcare workers and general public. Past evidence shows a high prevalence of unsafe injection practices among healthcare workers in developing countries. Research addressing the associated factors related to NSSIs among healthcare workers in developing countries are scarce. Therefore, regular surveillance of NSSIs locally and providing feedback to healthcare workers and administrators will help to prevent occurrence of these injuries. Objectives were to determine the prevalence and associated factors of needle stick and sharp injuries among healthcare professionals in teaching hospital Karapita and to determine the response following NSSIs among these people. This is a descriptive cross-sectional study conducted at Teaching Hospital Karapitiya, and the healthcare professionals, including nurses and doctors, included in the study, and consultants were excluded. Data collection was done using a self-administered questionnaire. Data analysis was performed using SPSS statistical software, and Chayes-Scar test and logistic regression was used to identify the factors associated with NSSIs. Ethical approval was obtained from the Ethics Review Committee of Faculty of Medicine, University of Rona. Permission was obtained from the director and the relevant consultants. Moving on to results, a total of 332 healthcare professionals at Teaching Hospital Karapitiya participated, and majority, 69.3%, were nurses. Mean age of the study population was 35.7 years. Among all, 81.6 were females. Regarding current place of work, 30.4% of the study participants work in surgical units. Majority of the study participants have worked for more than 10 years. Regarding hepatitis B vaccination and antibody status, 73.5% have completed 3 doses of hepatitis B vaccination, and 78.3% have checked their hepatitis B antibody level following completion of the vaccination. Regarding prevalence of needle stick and sharp injuries, a total of 65% had exposed to these injuries during their working period. Prevalence among doctors compared to nurses were high, but it's not a significant difference. Regarding factors associated with needle stick and sharp injuries among healthcare professionals, institutional factors and characteristic of the study participants, including knowledge on bloodborne infections and incidents, and the practices related to safe injection practices were assessed. Regarding institutional factors associated with these injuries, frequent contact with blood, training experience, availability of PPE, and hand washing facilities were assessed. None of the factors were significantly associated with exposure to injuries. Regarding knowledge on bloodborne infections, mean score of knowledge was 64.5, which was taken as the cutoff point of all. Only 57.7 had satisfactory knowledge. Doctors had significantly better knowledge compared to nursing officers. No significant difference between the knowledge and the exposure rate. Regarding the practices of the study participants, good practices, among good practices, wearing gloves during handling and processing of blood body fluids was showed lower the risk to get these injuries, and the recapping needles after drawing blood from patients have a significant impact on the injuries. Regarding post-exposure prophylactic measures adopted by the exposed participants, majority of 67.7 had informed infection prevention committee in the hospital, whereas in 69.7 informed ward theatre sister following an occupational injuries. And surprisingly also they have washed wound exposed areas with soap and water. And conclusions and recommendation, a high prevalence of NSSIs observed among healthcare professionals. A significant association was found in between wearing gloves during handling and processing of blood and body fluids as a protective factor, whereas practicing recapping of needles after drawing blood as a risk factor. It is necessary to enhance hepatitis B vaccination coverage and assessment of immune status among all healthcare workers. Regular training programs and adherence to safety precautions need to be encouraged to minimize the problem. Finally, adequate supply of personal protective equipment at healthcare settings is recommended to prevent exposure to blood and body fluids. These are my references, and I would like to acknowledge Director, all the consultants, the doctors and nurses who participated in the study, and at the end, to the organizing committee who gave me this chance to present this study results. Thank you.
Thank you very much. Paper opens for questions and clarifications.
Yes. Yes, data were collected through self-administered questionnaire. Yes. Yes.
You had some idea?
It was not actually, it's not done to that level. It's not one of our objectives.
I was a RE, and we observed that a lot of doctors are not adhering. Nowadays, without adhering to these.
Yes, thank you for raising this question. I think, yes, regular surveillance is important in that case.
The other question is most of the injuries have been notified. Have been notified to the hospital
Unit as well as the yes. Yes. Yes.
Okay, thank you very much. We will conclude this presentation.
Thank
so
you.
thank you very much.
Thank you,
And
sir.
We'll move to the next presentation.
Third presentation, the title is Fall Incidents Among Hospital Inward Patients in Teaching Hospital Karapitiya and Related Factors. The authors are Ubesekara NH, Mudannayaka MC, Sevandi KPA. It will be presented by Ubesekara NH. Over to you. Yeah, can start.
Dear head table and the judges and all ladies and gentlemen, good morning. I'm Dr. Nishani Ubesekara. I'm the Deputy Director of Teaching Hospital Karapitiya, and I'm presenting today one of our survey, the part of our survey, false incidents among hospital inward patients in Teaching Hospital Karapitiya and related factors. So I want to share this data with our community. The prevention project. And the background, the hospital falls remain a frequent and debilitating problem worldwide. And around 25% of hospital falls are injurious. And the resulted fractures and head injuries, and so the lot of injuries. And hospital inward falls increase morbidity, mortality, and increase hospital cost with unnecessary investigation, prolonged hospital stay. Most hospital fall prevention strategies have targeted, based on this data and the education, the environmental modification, and the reviews and all. And Teaching Hospital Karapitiya is the third largest hospital in the country with 70 wards, and started reporting the incidents in 2018. And for last 5 years, falls were the commonest incidents reporting and observed as the main safety issue among inward patients.
So preventable interventions needed to implement, and the unavailability of adequate data was a problem. And the study was carried out to fulfill that gap. And results of the study will be helpful for the hospital administration as well as to health authorities to improve the quality of care and safety. So objective is to describe the fall incidents among hospital inward patients in teaching hospital Karapitia and related factors. So this is a descriptive study, the one part of the three component study. And teaching, it was done in teaching hospital Karapitia. Study population was patients had fall incidents during their hospital stay. Inclusion criteria, patients who had fall incidents during 2018 to 2023 and reported in incident database were included. And the study sample was 698 patients. All the patients were taken to the sample. So data collection information sheet was used to collect data from the adverse events, the register and bedhead tickets and the review reports. So data analysis was done using SPSS and descriptive statistics and chi-square statistics used to show the related relationships. And the results, the 698 fall incidents yearly distribution was given here. And the majority were male patients, 61% of them were males. And the age distribution among the falls incidents, the falls were commonest among 51 to 70 age group and also the over 70 age group. So altogether 73% from over 50 age group. And the distribution of patients according to the place of fall. So we observed 77.3% from pediatric wards and mainly the medical wards, the oncology wards and surgical wards. Because of the casualty days, these wards have 60 beds, but more than 600 patients are there during the casualty days. And oncology ward, throughout the year, it's like that. So overcrowding was a problem we observed. So types of falls, most of them were the fallen from bed, followed by slipped on the ground, 24.5, and fallen in the washrooms, 17.6, and the others were fallen from chair and the trolleys. And time of fall, this was important to plan the prevention project. So we observed early morning hours, the patient engaged in washing and they had more falls than the time of the day. So the related factors, the only age was related to the type of falls. We analyzed the type of falls and the relationship with the age and the gender and time of falls. We observed only the age was related to the type of falls. And the outcome of falls, no reported mortality and no permanent disability, but the injury pattern was the 41% had head injury observation, and 5% had fractures, and 7% had injuries needed further investigations, and 62% had mild to moderate superficial injury. Conclusion and recommendations. Falls were common in all age group and age has significant relationship. Falls were common among male patients. Time of the fall and the place of fall give important evidence for preventive measures. Recommendations need further research on impact of falls to patient and hospital. We are now conducting that. The other components were the precipitating factors and the social and economic impact. And identifying high-risk patients, close observation of high-risk patients and infrastructure improvement need. And above interventions can be planned with the identified risk groups and in the high-risk wards. For the completion of the presentation, so what I explain here what we did based on these results. So we have taken some preventive actions, strengthening of incidence reporting, hospital surveys, and hazard identification at ward and the outside of the hospital, the wards. And we introduced checklists to identify risk patients, and we allocated 2 beds close to the nursing station to observe these the high risk patients, high fallen risk patients, and corrected. We do ward rounds and we corrected identified risk infrastructure hazards, and we review all the falls in the wards with the quality unit. And this is our risk assessment chart. We do it on admission. So especially now the high fall is the wards with high fall incidents. And this is what we achieved. So we strengthened the reporting at end of the beginning of the 2019, and we had more reported incidents. And we introduced end of the 2019 based on these results, the prevention projects, prevention activities, and you can see the reduction of false incidences. The reporting is normal, and the reduction is due to the prevention activities. Thank you very much.
Thank you, Dr. Ubesekar. It was a very interesting presentation. I think you are the deputy director of the hospital.
Yes.
So I think it's very important that you had done this thing. And today in the morning also we had a talk on these falls. And I think it's highly
Yes,
I mean,
madam.
commendable that
They
you also-
mentioned that no prevention projects inside the government hospitals,
right,
but we
yeah.
do this project for now 3 years time. So
Okay.
we are improving with the data and the observations we do.
So that's a very
Yeah.
positive step forward. It's very
Thank you.
interesting.
Thank
Okay, thank you. Any questions, please? Yeah. So actually, I just want to know who fills this adverse event register?
Madam, there's a nurse, the registration counter in the wards. Admission nurse is there. So we have introduced the risk assessment charts to the wards. Initially, we did in pilot wards. The false incidences are high. The wards in false incidences are high. The surgical, medical casualty, pediatric, and the oncology. And they fill the assessment chart, and they identify high-risk patients. And last year we started this allocation of beds close to the nurses station, and we gave tags, risk tag for those beds, and we put the high-risk patients to the ward, those beds, and they can closely observed. They can be observed.
Yeah,
by
regarding the time of fall, again, did you, the nurses are the ones who filled it up?
Sorry, ma'am?
The time of the fall? Time of the fall?
No, ma'am, we are reporting system. So we have reporting system, false reporting system. All the falls, they have to report to the director. And we have started database in the quality unit. And now we have database. So we record the time of fall and all this data in the register database.
Any more questions? Okay, thank you for that very interesting presentation.
Thank you.
Okay.
Next, move to the next presentation, that is on factors and outcomes related to practice, presenting after falling from the height and admitted to the intensive care unit in Teaching Hospital Peradeniya. Jayasundar SS and Samara Singh SUD. Jayasundar SS will present the paper.
Thank you, sir. Thank you, madam. And good afternoon, everyone. Today, my talk is on factors and outcome related to patients presenting after fallen from height and admitted to the intensive care unit teaching hospital Peradeniya. As described in the morning talk, WHO defines the fall as an unintentional event that results in a person landing on a ground or a level lower than their starting point. As such a fall from height refers to drop from a higher level to a lower. So that leads to multiple injuries, and eventually patients get disabilities and deaths. I am an emergency medicine registrar, during my ICU rotations, I have come across frequent admissions following fallen from height to the ICU care with poor outcome. So in Sri Lanka literature, there is a lack of data among those injuries, and me and my supervisor thought of to do descriptive study to fulfill the gap in those data. So we were interested in find out the association factors like age, sex, alcohol, consumption, occupation, and seasonal variations affected with this presentation and outcome. Regarding the background, the number of deaths caused by the falls on the rise globally with 650,000 annual deaths. It is 80% happened in low and middle income countries. In Sri Lanka, falls account for 3% of all traumatic injury deaths. Major life-threatening injuries caused by falling from heights require immediate admission to the ICU, and there are various contributory factors to fallen from height. So as described earlier, objectives was to assess the outcomes of patients falling from height and analyze the socio-demographic factors versus ICU outcome of patients following fallen from heights. So this was a descriptive cross-sectional study. A study period was January to July 2023 at ICU, Teaching Hospital Peradeniya. The study population was all patients admitted to ICU following fallen from height during the period of 2017 to 2023. Up to today, exclusion criteria were deliberate suicidal attempts. Sampling method, consecutive sampling method, and data was collected, interviewer administered questionnaire, and collection data reviewing the BHTs of all eligible patients, and principal investigator personally reviewed all selected BHTs and, if necessary, contacted the patient's guardian using the telephone numbers provided in the BHT to clarify any uncertainties. The results, majority were males, 90%, and the mean age was 51 years. The mean height from which they fall was 22.1 feet. Out of the victims, 85% of them were not under the influence of alcohol. Out of all, 75% were witness incidents that had a statistically significant association with the outcome. The time to reach the primary medical care institute is less than 1 hour, as well as victim found unconscious at the site did not show a statistical significance in relation to the final outcome. And there were no significant difference between socio-demographic factors with the outcomes. So my conclusions and recommendations are witnessing these incidents were directly related to the ICU outcome of patients following fallen from height. And extended analysis of the causative factors versus outcome is necessary to provide recommendations on injury prevention. And thank you.
Thank you. Paper opens for discussion and questions.
Said alcohol is one cause.
Yes.
Are there any other medical factors for this?
In questionnaire, madam, I inquired about other medical factors, but there was no significant association found out. Those males were medically healthy. A lot of patients? What are the types of medical causes that you found?
That even they
No,
are
I
significant.
inquire about NCD diseases, madam, like myocardial infarctions, diabetes, heart failure, like that, those, madam. But there wasn't any significant association with the fall, madam.
Any other questions? So let me ask a short question now. It says unconscious at the site was not associated with the final outcome. So I was wondering, was the unconscious was reported by the patient itself or in the BHT secondary data?
From the GCS, sir. From the
At
BHT
the
GCS.
time of admitting the patient to the hospital.
Yes, from the to the primary care facility.
Okay. If there is no other questions, we will conclude the presentation. Thank you very much.
Thank you.
So we move to the final presentation. The title of the final presentation is Intervention Project to Prevent Falls in Hospitalized Patients at Base Hospital, Udugama. The authors are Fernando GHS, Patirana PPAS, Seniviratna AAS, and the paper will be presented by Fernando GHS.
Fall prevention. Fall prevention. Good morning again. I am Dr. Susantha, Medical Superintendent, Base Hospital, Udugama. Base Hospital, Udugama is a 150-bedded hospital type A. We have all main specialty with 5-bedded ICU and 24 service given to the theater complex. I think I don't need to justify need of intervention to reduce hospital fall, because previous presentation from the Karapitiya clearly justify why we need intervention to prevent hospital falls. The patient falls are most common adverse event reported in the hospital, especially developed countries, maybe because most of the people are elderly patients. 2% of hospital patients fall and 1/4 result in injury. These are the findings from the developed countries, and 10% result in serious injury. The injuries and fallen, I don't need to justify, already mentioned. In our hospital, 10 patients have been fallen within 18 months. Then because we do this intervention not just only to address our issue as a proactive intervention. So we know fallens are happening everywhere. Even my previous hospital, even Karapiti, I was a deputy director in 2017. I heard this is the only incident reported to the director without informing to them, because they think this is something happened legally, the in-charge nursing officer will be affected. Therefore, without implementing, automatically they report this incident. I think all directors know that. we identify root causes from our quality management unit. We have quality review meeting. We identified because of high workload, we have only 17 nursing officers per where we had 250 nursing officers in my hospital. My whole hospital with theater ICU run with 72 nursing officers. Where workload is very high. We don't have assess the risk, and the poor documentation, poor education on staff always as patients, and lack of staff awareness. These are the reason why these 10 or 18 patients were fallen, 10 patients have fallen in the bed or the washrooms. Then our objective was to reduce patient fall during hospital stay. I think this intervention, as a small hospital, we easy to implement, and we can benchmark to the other hospital as well. Method, the intervention project was developed with the help of all the stakeholders, including consultant medical officers and our nursing staff. Then with them, we developed the risk assessment format, risk assessment chart, and we developed risk dashboard, where I will explain that, and prepare risk, fallen risk tags, and sensitization of all the staff on the intervention, and conducting risk assessment on admission and implementation of the preventive project. This is the stakeholder meeting we conducted with our staff members. This is the risk assessment chart. This was developed with the help of our consultant and doctors and nursing officers. The risk rank was developed by with the knowledge and experience of consultant and doctors and nursing officers. We collectively give information to them and ask them to put what is the risk of fall rate for up to 1 to 5 for these reasons. All give some mark. We collect at all and get the average number. This is a risk of fall number. We develop this one. There are standards in national, international, but we develop as a practically, it will be easy us to implement if we get information from our staff. According to that, if it is a risk, if we identify as a risk, these are the things we are doing for the patient. You can keep in high risk patient in a bed, protected with bar, offering bed near to the washroom to the patient who have difficulties, keeping risk tags at the beds, making the entire staff well aware, educating staff to offer a friendly service to the risk patient, allowing to keep a bystander for high risk patient, notifying fall risk places in wards, preparing disabled toilet to each ward, educating the patient on risk of fall and preventive actions, fixing bed alarm beds, still we are not did, keeping the floor dry as much as possible. These are things we should, if you have identified as a risk of fall, we have to do these things according to that. This is the risk categorization. If the ones with the this is once patient come to the ward, nursing officer and the doctor collectively fill this format as a collective effort. After then they fill the chart. If the risk is more than 4, we take as a high risk. All the preventive action we take, and addition to that, we recommend to keep bystander. If it is 3, it's a moderate risk. All the preventive actions without bystander, we don't recommend to keep bystander. For if it is moderate, it's low risk. Awareness of both patient and staff are done this. On admission, the all nursing officer, doctor fill the risk assessment chart, identify the risk of fallen. If we identify the risk, all the measures I explained before will taken, then this is our risk board. If there are not 3 patients in the risk of fall, we notify here there are 3 patients in this ward who are risk. Then all the entire staff, even minor staff, know about this thing. They know if this is there are a number of patients, they know they have to do something these patients. it is not only this, we are doing this improve quality improvement project. There are several dengue hemorrhagic fever, allergy patient, fasting. If they are such a patient, we mark this number here. All are know these patients available in our ward. Once this happened, we give all the precautions has been taken, and this is a risk for tags. There are tags. If it is for a risk of fall, this tag is attached to that bed. Then all know the visualization is very efficient or effective. Therefore, we can visually see these. There are no patient. That risk tag also there. All are know this patient is risk. Then even patient know we have educated. Then they know I will be fallen. He will get precaution. In the bystanders, no. Even minor staff, all are know she will be fallen. Therefore, we take necessary actions to prevent falls. Result, intervention was commenced on 1st of July 2023. Observe for 3 months. All the staff members are very satisfied on the project and adherent to the intervention. Number of patient identifies during risk assessment 20 identifies a risk of fallen, and intervention was done. No fallen reported during 3 months. Patient falls are reported during hospital stay cause harm. Falls can be reduced by implementation of prioritization of risk patients. Visualization is more practical, even a busy environment to reduce risk. Sorry for mistake. This is a project. This is why I implemented my hospital. This can be implemented to the other hospital and even Karapiti. Thank you.
Thank you, Dr. Fernando. It was a very interesting and a very comprehensive study that you had done. And yeah, I think it's really important because you have done this intervention study and you have developed this particular instrument also, which is also very important, which can be used by other hospitals as well. So it's open for discussion now.
Thank you for the presentation and to taking this initiative to reduce the risk of falls in the hospital. You have mentioned that there were 10 falls over the 18 months. Yes. And can you mention the incidence of falls like?
The incident reporting system has been implemented in our quality secretarial since around 5 to 6 years. Mm-hmm. In our hospital, incidents reporting system has been established from 2029. Each and every incident reported to our incident reporting system, we are doing evaluate. We do each and every incident at our review meeting.
No, what I wanted to know is what is the total number of admissions during that period of which you have got 10 falls?
Yes. Actually, now I can't tell, but daily our admission is around 70.
Okay.
Average admission 70.
Okay. One more thing. You have mentioned that you have categorized the risk based on your score. And may I know how you determine these cutoff values?
This is why focus group discussion. This is one of method. We are developing some tool with professionals. Mm-hmm. We took all the consultants, doctors and in-charge nursing officers. We sensitize all the participants regarding this our value, and they ask them to study, learn about this thing, get your experience and knowledge, and we make 1 to 5 marks. Please give mark which is the risk of fallen for that reason. They mark. Then one consultant give 5, sometimes one consultant 4, according to their knowledge and experience.
Yeah,
after that, collectively we add all the things and divide it by participant and make a risk number. This is a initiative because something is there nothing. This we started that, but this is not a project stop from today. Now we are continuing. We are evaluating regularly. If any adjustment, we will change it.
Any more questions? Otherwise, we will be able to conclude this presentation.
Thank you.
Thank you very much. Now we have come to the end of the oral presentations. There were 5% very interesting presentations. So again, thank you very much for all the presenters to make the session on time. And actually, we started a little late, but we were able to finish on time after this presentation. In fact, two presentations were based on the hospitals and the interventions they have made in the hospitals, and they are actually very good examples for the other hospitals in our health system as well. And also we heard a presentation, oral presentation from the findings of the University of Hull, which is, I think it's a good lesson for us, and it may be applicable for our countries as well, looking into the rapid review reports in future and where it is not applied so far. And also other presentations were based on the socio-demographic characteristics of the patients, as well as patients admitted to the ICUs and how the health outcomes and what the associated factors are. Altogether, in general, we got a good idea about the this aspect, this discipline, and which make us to learn new things, and probably we'll able to apply the new things in our health systems as well. Thank you very much. Over to you, madam.
Yes, I also need to conclude saying that was very interesting. And actually, it's so nice to hear that some of the hospitals are doing their own interventions on how to reduce the types of injuries that are occurring in the hospital. So it will be really good if the other provinces also can take this take-home message, right? That these things can be done in the other hospitals as well, and where we can reduce the falls in the future. Thank you very much. It was very interesting presentations. Thank you.
Thank you very much for that active participation. Let's give a round of applause to all the presenters of this session. Each one of them will receive a certificate of participation, and the best oral presentation of this session will be awarded at the end of the day after the plenary at the grand ballroom upstairs after this session. To present the certificates to the presenters, I warmly invite the chairpersons, Dr. Sumal Nandasena and Professor Sampatha Gunawardena. Sir and Madam, please come forward. Starting with Fernando GHS. Followed by Vikramasinghe SS. Next, Ubesekar NH. Followed by Jayasundara SS. And again, Fernando GHS for his second presentation. We express our sincere gratitude to our esteemed judges of this session, Professor Mahika Senemi Vikrama, Head of Department of Community Medicine, University of Sri Jayawardenepura, and Dr. Nadija Herat, Consultant Community Physician, Estate and Urban Health. I warmly invite the chairpersons again to come forward to present the token of appreciations to our esteemed judges. Your commitment to this symposium is deeply appreciated. Thereafter, I would like to invite Dr. Sherin Balasingham, Consultant Community Physician, Non-Communicable Disease Unit, to present the token of appreciation to our esteemed chairpersons, Dr. Sumal Nandasena and Professor Sampatha Gunawardana. Respected chairpersons and judges, presenters, before we move forward, let us seize this moment of collaboration and knowledge sharing. I invite you all again to join us for a group photo. And the presenters, please. Thank you very much. As we have come to the end of this free paper session 5, I invite you all to join the grand ballroom upstairs to participate at the plenary, followed by the award ceremony. Thank you.